Welcome back to Beyond the Prescription podcast. Today we are interviewing Alex Waldherr. He is now an Olney native. Been here a couple of months, couple of years. How long have you been here?
So officially a couple of months. I've been coming to Olney since 2021 is when I met my wife. So around Christmas time, 2021 was the first time that I was here. Got to see lights in the park. Got to, be a part of the community and meet my wife's family. They're amazing. Felt like home pretty much from the get-go. And now here we are, almost 4 years later, and we have a dog together, and we're married, and we have a house, and we're, I guess, transplant Olney native for me, and for her, it's just a homecoming. So.
Do you care to share with us who your wife is?
Oh, yeah. So Elise Waldherr, previously Elise Eagleson, is my wife. So we met in Indianapolis. She was working in interventional radiology nursing at the time at IU, and I was a resident at the family medicine residency on the south side of Indianapolis at Franciscan.
Okay, very good. So you settled in, you've been here officially for a few months, and you are kind of the main show down south of town here in Olney. Where at?
So we have the new Wabash General Hospital Olney Medical Clinic just right on the other side of the Red Rooster. So if anybody's seen that construction going on over the course of the last year or so, that's what we've been working on. And really just trying to fill that space and offer a service to folks here in the community that, is something that is needed, and provide a pathway to, getting relief for different sorts of aches, pains, sports injuries, that sort of thing. I'm a primary care sports medicine doctor by training, so I don't do surgery. I do a lot of joint injections, that sort of thing that kind of constitutes the non-operative management, the conservative management, so to speak, of musculoskeletal pain. And then once those options are exhausted, we have a fantastic group that does all sorts of different surgeries that could potentially be a more long-term lasting solution for folks.
Okay, so you're here how many days a week?
So 4 or 5, depending on the week. So
nice.
I have an injection clinic with ultrasound guidance in Mount Carmel. We're slowly ramping that up. Hopefully, with time, that can continue to grow, and I can offer services in multiple locations. But right now, we're just doing one day a month that I'm in Mount Carmel. So there's 1 week of the month that I'm here 4 days, and the rest of the days I'm here,
Good.
The rest of the weeks I'm here 5 days a week.
Awesome. So you're here 5 days a week, and you're able to see kind of all of the things in regards to all the way from sports medicine of sprained an ankle all the way to some, chronic osteoarthritis or something.
Absolutely. So
beautiful.
Lots of different things kind of across the board. I mean, sports and activity looks different for everybody. So, we take all comers, and, if there's something that we can be helpful with when it comes to musculoskeletal pain,
good.
That's what we're here for.
So right now we're in kind of the tail end of like the middle of the football season. Football, basketball, track, all of them, there's lots of different injuries. But one thing that we see in primary care, and also I'm sure you really see, is concussions.
Yeah.
So give us some information, give like the community, what are like the signs of it? What are the risks for going back into sports? What are the long-term effects of it? Like, give us
absolutely.
all that information.
Obviously, concussion is a very, hot button issue for sports and sports medicine. There's a lot of attention paid to professional football players and, potential sequela of head injuries later on in their life. But of course, that all starts now during high school football, youth football, non-football sports. I mean, you can get a concussion in soccer. You can get a concussion in basketball. There's, no, rhyme or reason. Sometimes these things just happen. Honestly, I saw quite a few concussions from cheerleading when I was in my fellowship, just because when you're doing stunts and you've got ankles, feet flying around, sometimes those land on people's heads too. So concussions can really come from any sport. The threshold for being concerned about a concussion is actually a lot lower than most people realize. It's really the only two criteria for being concerned about a concussion are a head impact and some degree of symptoms. So those symptoms can be different for everyone. It can be sensitivity to light, sensitivity to noise, nausea, dizziness, lightheadedness. Some people have altered levels of consciousness. Those tend to be more severe concussions. Ringing of their ears, all sorts of different things. I've gotten a bunch of different complaints on the sideline that have kind of got my spidey senses going and thinking, okay, you're describing this, but after what I just watched happen, there's other things that I'm concerned about too. And you got to make sure that you listen to the patient that you have in front of you because they want to know about their primary concern. But sometimes when you're on the outside looking in from, that vantage point, you may have other concerns that you have to take care of too to keep that patient protected and protect them from going back in and having something kind of like you already alluded to, like second impact syndrome. So if, they go back in when they have a concussion already and then have a subsequent head injury, the length of the concussion can be significantly longer. The severity can be worse. Lingering symptoms can be worse. And then with repetitive injury, then we're starting to think about things like chronic traumatic encephalopathy or CTE, which is like the big buzzword with the NFL and long-term head injuries from concussion.
So what are the current guidelines right now?
So the most up-to-date is the SCAT-6 or the SCOT-6, depending on whether you are on the sideline and administering those tests live, just happened. This is a sideline test to determine, can you go back in, can you not go back in? The SCOT is designed for the office, so the extra O in the acronym stands for office or outpatient. Really those are the most up-to-date guidelines. So those came out during the last couple of years. We were using the SCAT-5 before that, and then we've just progressed to the SCAT-6. So those tests include memory of, a random set of words. Can you remember a sequence of numbers? Can you then say the sequence of numbers, backwards? Different questions and different varieties of things like saying the alphabet, every other letter backwards. Some of that's hard for people who are not concussed, myself included. So, some of these things really do make you think and kind of provoke, or I guess really put a mental workload on these patients so that you can kind of pick out, okay, this is more difficult than it should be for someone this age. And that's kind of where the art of medicine blends with the science too, because there's also components of the assessment for balance and things like that. And, some of our football players don't have the greatest balance. So you have to think about, okay, well, what's normal for this patient compared to what are we dealing with now?
When are you going to send somebody to the emergency room?
When it comes to actually being concerned for, an intracranial bleed or something like that, we're looking for clear neurological signs. Loss of consciousness doesn't always have to be, but oftentimes that's a big trigger for a lot of folks when, you see somebody that's out like that. You want to make sure that there's nothing more sinister going on. And a lot of the time, the things that would be more concerning to me for intracranial bleed would be different sized pupils, having difficulty, with coordination to the point that, they can't speak properly, they can't answer questions. I mean, we typically will ask folks, hey, what's your full name? Where are you right now? It's a lot of avoiding yes/no questions and using questions that actually provoke thought so you can actually see that their cognitive functions are still intact and doing what they're supposed to do. Really, there's that component of it. I'll also sometimes uncover things that are concerning to me on physical exams. So, there's a phenomenon known as nystagmus when your eyes are moving back and forth and we see a little bit of twitching. And when you're going horizontally, some people have that at baseline, regardless of concussed, not concussed. It's just something that some people have. Going up and down, though, that's never normal. You should never have that twitching, that nystagmus when you're going up and down. So things like that are more concerning. And then we also do a number of different vestibular maneuvers that check, those semicircular canals in the mid-ear to see, hey, are you processing information correctly? And that's what I focus on with kids a lot of the time is, hey, if you can't do these tasks, you know, because nobody wants to be concussed, nobody wants to get pulled out of, you know, they might be having the game of their life and then something happens and they're being told, hey, even though this is, you know, the best you've ever played, you're going to sit down and you're not going back in. And that's a tough conversation. It's not a fun conversation to have, but I think when you present it as, hey, if you can't do these things on the sideline, are you coordinated enough to catch a ball? Are you coordinated enough to receive the handoff from your quarterback? Are you able to protect the other members of your team, or is the defender going to run right by you and then somebody else is going to get hurt because, you know, you weren't able to do your job? And I think framing these things that way for athletes makes it a little bit easier to understand why we do what we do in terms of not only protecting them, but also protecting the other players on the field too.
Yeah, a lot of it is just like that education. For
Absolutely.
Sure, so.
And I know a lot of people don't give our young athletes as much credit as they deserve for being able to understand and like accept those things. And I think that if you really do take the time on the sideline to have those conversations with kids, more often than not, they're going to come around and they're going to understand. They might not be happy about it, but they can understand why, hey, you know, I'm a liability if I go back out there, not only for my own health, but for how our team's going to do. And sometimes when you frame it like that, it clicks a little bit more for the athletes.
A little deeper.
Yeah.
Yeah. I'm going to share with you my concussion story.
Yeah.
It wasn't in sports. I had been sucking helium, like the balloons, to make your voice sound funny.
Yeah.
And so I don't know how many I had done. I was probably like 8 or 9, but I was walking up the stairs after I had sucked up all this helium and got lightheaded, fell back stairs, had an intracranial bleed, and was in Wellborn Hospital for a long time. And I totally forgot about that until you started talking about the bleeds. I was like, yeah, that sounds familiar. So anyway, don't suck helium.
Yeah, no.
So you are part of like the Olney Tigers. Like, do you do anything with Olney Tigers on a routine?
So I'm on the side. I try my best to be at whatever I can.
Nice.
I've made it to every sport at least once this fall, and I'm going to continue to make that my goal for the winter, the spring as well. I'm passionate about that because I played a lot of sports in high school that were not really well attended. So
what'd you play?
I was a soccer player, which was, I feel like soccer's way cooler now than it was when I was in high school in like the early 2010s. But we didn't get a lot of folks at our soccer games because we were off-site a lot of the time, and we were not actually playing on the field at the high school. So we didn't see a lot of support there. Swimming and water polo. So those
water polo. Tell us about that.
So water polo is, I tell people it's like the coolest sport you've never heard of. It's played in a pool, hence the water, but also it's basically like playing handball where you're trying to throw a ball into a goal. You got offense and defense. You've got a goalie. There's a shot clock like basketball. Very physical game. Lots of fouls, power plays like hockey. It's very fast-paced, very entertaining. I make it my personal mission every single time that it's on TV during the Olympics to make as many people watch as I possibly can because almost all of them love it. It's awesome. Really fun to watch.
Yeah, I don't think I've ever seen it for sure. So what are you primarily seeing? So you're probably doing... so like on the sidelines on the football field, you're doing concussion evaluations, but what is another injury that you see a lot on the sideline?
We see a lot of ankle stuff.
Yeah.
I think that's probably the most common. We see a lot of cramping, which, you know, just making sure that our athletes are doing okay. You don't ever want to say, oh, they're just cramping and then miss something bigger. So, and we've got a phenomenal athletic training staff here in town that does a really good job of kind of piecing through and making sure that they're leaving all options on the table and making sure that people, you know, are getting good quality care. But I would say ankle is probably the most common. There's, you know, a lot that we can do. You know, I grew up in the Chicagoland area, so thinking about like Walter Payton, like one of the greatest running backs of all time, was pretty famous for doing ballet and some other stuff to help with his footwork. And part of the reason that is so helpful is because it helps with the intrinsic control of the foot and those stabilizing ligaments on the outside of the ankle to prevent further injury.
So going back to the concussion topic, what is something that you want to tell across the board, like parents of athletes, that are some signs of, a head injury that they need to be concerned about? And then how many head injuries or how many concussions is it safe to continue, or when should you be getting pulled out of sports?
Yeah. And there's a couple of loaded questions in there for sure. So I think I'll start with kind of the more loaded one. There isn't really a consensus on removing somebody from sport when it comes to how many concussions is too many. When I was in high school, a lot of people kind of operated on the 3 strikes you're out rule. And then, there's also folks that, estimate that there's a bunch of undiagnosed concussions, and sometimes people are only really getting flagged for the ones that are bad enough to kind of trigger medical attention and have the AT get involved. And, that's why it's so important to have kind of an open dialogue with your children. And, if something seems off about them, and that they got hit in the head during a recent sporting event or not a sporting event, if, they came home with a big welt on their head and, they fell down the stairs at school or something like that. And, you've got to be on the lookout for those signs and symptoms. A lot of these resources like the SCAT, the SCOAT, all of those things are available online. And you don't have to know how to administer the entire thing as a medical professional, but there is like a little symptom checklist that's available on there that any parent can, be on the lookout for some of these things.
So where would they find that online?
I mean, I would just Google like SCAT, SCAT 6.
Okay. It's not like a specific organization. No. Okay.
No. It's been published by a coalition of different authors that are experts on the subject of concussion. So they kind of had like a conference of, respected professionals in the field that kind of came up with these consensus guidelines.
Okay.
So those are available to the public online. And you can look, I think the most valuable one is the symptom checklist. And oftentimes that's the one that we're kind of tracking numerically in the office the most closely, because that'll tell us, okay, they said that their headache severity was a 5 the last time we saw them, but today it's only a 1. Or today it's completely resolved and they're no longer having headaches. So those are the things that, parents can be on the lookout for. Some important myths that I think are important for parents when it comes to concussion. You don't have to keep your kid awake after concussion. That's not something that we recommend.
Yeah.
We also don't recommend just like having them sit in a dark room and just have zero stimuli whatsoever. We do want to challenge the brain to a reasonable degree and have them try to do as much of their daily routine as they can, and then back off when symptoms get worse. So just being aware of, okay, my kid is dealing with, really bad lightheadedness or really bad headache. How much can we tolerate? How much can we do that, we keep them on their usual routine. We don't let them fall super far behind in school, but we also know they're not 100% right now. So we have to have some reasonable accommodations in place to, and reasonable expectations as well. Another thing, just in terms of headache, specifically, it's important that you're not just, every 6 hours loading up with Tylenol, regardless of are we good or are we not good, because we do want to see when the headache stops and when all of that gets better. So if we're constantly on medication around the clock, it's really hard to tell when the symptoms have really ceased, or are we just masking the symptoms with medication? So when it comes to headache, I always tell folks, wait for the symptoms to present themselves first, and then give a dose of Tylenol. Don't just proactively say, okay, well, you're about to go to school. I don't want to have to worry about this throughout the school day. Here, it's 8 o'clock in the morning. Take Tylenol, even if you don't have a headache. We want to make sure that we're able to see what activities are provoking headache, what activities are provoking other symptoms of concussion. So we try our best to not mask them. We treat the symptoms when they arrive, but we try not to anticipate and prevent them.
Okay, awesome. Very good. Yeah, you did hit a few good points about not letting your kids go to sleep and all of that stuff. So the next thing that you kind of shared that you're pretty passionate about is getting people to their best quality of life. So sports medicine has a lot to do with teenagers, adolescents. It has a lot to do with young adults. It also has a lot to do with older adults too, correct?
Yep.
So shine some light on what your practice looks like for maybe the older individual.
So for older individuals, oftentimes we'll see folks who are just having increased pain in their day-to-day life, not even activities that are all that taxing. Obviously, being here in the Olney community, we have a lot of folks who have done a lot of very physical work for a long time. And with that more intense labor, comes aches and pains. As cartilage begins to wear away, as arthritis starts to get worse, and we see a fair amount of that. So, it's not uncommon for me to see somebody who, has been seeing their primary care doctor for some time and, has been trying to do some over-the-counter medicines and trying to do XYZ. Maybe they've been to physical therapy, maybe they haven't. It's kind of a mixed bag. Some people have come to me and they've already tried, scheduled anti-inflammatories, like prescription strength anti-inflammatories too. So they're coming to me having already done a lot of the basics. They've done physical therapy, they've done a prescription anti-inflammatory already, and they're thinking, okay, well, what's the next step for me? And for a lot of folks, sometimes that is like a steroid injection or something like that. That's a little bit more invasive than, the oral medicines that they've been doing, but not quite so invasive as doing a whole surgery for a joint replacement. Oftentimes that's kind of my wheelhouse, what I can bring to the table in our practice. And I do a fair amount of steroid injections. We do a little bit of hyaluronic acid, like gel injections as well. That's something that's continuing to evolve and will continue to evolve.
Is that
as well.
what some people call like the rooster shot?
Yep, rooster comb. Yep, that's all kind of synonymous for kind of that thicker, more gelatinous substance. It also produces or triggers the production of more synovial fluid in the joint that you inject it into. So there's like a little bit of a physical barrier in there as well as having a little bit of like a biological effect.
How many can you have of those?
So typically, depending on the manufacturer, they all have different guidelines. So there are certain folks who will do a series of 3, and we do 1 shot a week for 3 weeks, and then we can repeat that again in 6 months. And that's kind of a typical regimen, regardless of whether you're doing it's a one and done shot and then repeat it again in 6 months, or a shot a week for 3 weeks and then do it again in 6 months. It's usually the 6 month time window.
Does insurance pay for like the once a week for 3 weeks, or are they more like once every 6 months? Or
it depends. Most of the time, I haven't had too terrible of an experience with insurance when it comes to covering the once a week for 3 weeks. The volume of doing it that way is a little bit more, so there's a little bit more of the actual gel. So for some of the patients that have more joint space loss and more advanced arthritis, sometimes that makes a difference. And sometimes people, really don't respond to the medicines. And I think that that's an important part of, being a physician too, is saying, hey, we have these options available, but also making sure that they're aware of, if this doesn't work, then here's where we go next. Because sometimes I'm going to do something for somebody and it's not going to help, and it's not going to be of significant benefit. And then, that's not the end of the world at that point, because we've already talked about what our next steps are. We've already kind of established, okay, here are the options that I have for you, and then we're going to get to a point that I'm not a surgeon, and, you may need to consult a surgeon for further options. And, we have the ability to plug you in with great people that we have that do this procedure, that procedure, whatever it is that you need.
Awesome. So you shared what you're passionate about. Explain that on what you define sports medicine as.
Yeah, and I think that a lot of it, and a lot of what I kind of hope to do with my practice, is really to redefine sports medicine for folks, because I think that a lot of people have a preconceived notion that sports medicine is a subset of medicine that is specifically for athletes, young, healthy people. I don't have anything to gain from, working with a sports medicine physician because, I'm, doing a job every day. I go out, I work hard, I'm, in the fields or, in a factory or doing something like that. And, all of those biomechanical processes make you an athlete, regardless of whether, the thing that you are trying to do is to accomplish a task at work or accomplish a task on, a court, a field, a pool, whatever it is. So I always tell folks that, for a 70 or 80-year-old, their Super Bowl might be just being able to make a lap around Walmart, get all the groceries that they need, and then not feel like they're out of commission for the rest of the day and still be able to go about and do, their normal activities of daily living. ADLs are a really big thing that it's a huge buzzword in medicine, but I think that really having those in mind and having those as a core focus as a physician is just a really good guiding principle for how you should be practicing. Because if someone feels like they can't do what they need to do to live their life the way that they want, then there's room for improvement there. And I think that, what we're doing in our practice, I think that we can help a lot of folks who are falling short of those goals. And, if there's not something that we can do directly, then we can at least get them in touch with other resources that can potentially get them to a better place. So that's really what I kind of pride myself on is, even if I don't know the answer, I'm going to get you to someone who does. And, that's part of that is my background in, primary care and, being from the training that I am from, because there were plenty of times where I knew that, the problem wasn't going to be fixed by something that I was capable of doing.
So you were in primary care?
So I did family medicine residency first, and then I subspecialized further by doing a sports medicine fellowship. So,
I see.
Non-operative sports medicine physicians can come from really any of 5 specialties. Family medicine doctors, internal medicine doctors, pediatricians, emergency medicine doctors, and physical medicine and rehabilitation doctors can all pursue a primary care sports medicine fellowship. So, if you see a sports medicine doctor, it's likely, it's pretty much certain that before they did their fellowship, they did residency in one of those 5 specialties.
Okay, great. Very good. Well, we really appreciate you being here in Olney. So that's super great for our entire community. So welcome. And it sounds like you have got some big family ties here. So that's going to hopefully keep you here for a long time, right?
Yeah, we're really excited to be here. It's been nothing but a welcoming experience from, the Olney Tiger family. I'm looking forward to working with OCC later this winter when their sports get going a little bit more. And really since 2021, it's felt like home from the very beginning, and now it is. So we're looking forward to calling Olney home for a long time, and thank you very much for having me. It's been really nice to have the opportunity to chat.
Thank you for joining the Beyond the Prescription podcast today as we interviewed Dr. Alex Waldherr. He is here at Wabash General Orthopedic Clinic down south of town behind Red Rooster. So we are thankful for him and his services and what he can help you to do as a patient who could be suffering any type of joint pain or anything like that. So thanks again for joining, and keep listening so we can help you thrive.